Good morning, respected consultants, seniors, my dear colleagues and juniors. Today I, Dr. Rishu Bansal, welcome you all to the World Neurosciences Summit 3 2022 being organized by Dr. Arun Garg sir and Dr. Sudhir Dubey sir, and thank you all for gracing us with the vast knowledge of neurology by the teachings of the stalwarts of the field in India and the world. So without further ado, let's start the sessions for today. Our first session is on Neuro Ophthalmology. Our chairpersons for this talk are C.S. Narayanan sir, Jaideep Bansal sir and Pawan Dhull sir. Dr. C.S. Narayanan sir, he is the HOD and consultant in the Department of Neurology, Manipal Hospitals, Delhi. He is also the former HOD Dean of RR Hospital, New Delhi, and he has various other achievements and awards to his name. So we have Dr. C.S. Narayanan sir. Chairing this session is also Dr. Jaideep Bansal sir, who is a senior consultant neurologist, the director and HOD of the Department of Neurology, Fortis Hospital, Delhi. We also have Dr. Pawan Dhull sir, who is the professor and HOD of Army Hospital, RNR, Delhi. I request the chairpersons to kindly introduce our speakers for this session.
Good morning, everyone. Welcome to this morning's session on Neuro-Ophthalmology. It's great to be the opening batsman. And there are three talks for this session. One is on acute vision loss. The second is on the approach to double vision. And the third one is on supranuclear gaze paresis with a special emphasis on nystagmus. I invite Dr. Aastha Takkar to take the stage and deliver the first talk on acute vision loss.
Very good morning to all. I'm Dr. Aastha, and by the time these logistics are sitting up, I would want to thank Professor Arun Garg and his excellent team for organizing this mega event, and many hearty congratulations, and a lot of thanks for letting me be the opening batsman, I would say. So today's the session, the theme of this session is the eye on the sky, and I would say let's go beyond the sky to the horizons, and as of now, let's discuss about blackout or acute visual loss. So I would say optic nerve is the only fascinating nerve which exists both inside and outside the cranial cavity, and its existence outside the cranial cavity also helps a physician to make it the only individual nerve which can be visualized by a clinician. So it exists outside in the eye, it exists as optic nerve, and the vision pathways go on inside the brain. Maybe this is the only reason why the patients also keep footballing between the medicine OPDs, being the neurology OPDs, the neurosurgery OPDs, eye OPDs, failing to know what is the single common cause of visual loss.
So acute visual loss always has to be seen under the context we are discussing it too. A patient with visual loss, a single patient with a single history, same history of visual loss, can be having either an eye problem, an optic nerve problem, a brain problem, and that is why the context is extremely important while dealing with patients of acute visual loss. Let us just see this single patient who came to us, a young boy, who came to us only with decreased vision from the left eye of 12 hours duration. Because the patient had some small papules in this area of the forehead and the eyelid, the patient went to the medicine OPD, and the patient was diagnosed as a case of optic neuritis bar increased ICP based upon this fundus imaging. So I think there is nothing, there's no rocket science to see that this is an optic disc with florid hemorrhage on it. But what is important is that when the patient, by the time the patient reached the neurology OPD, you can also notice that apart from this optic disc, there were extensive hemorrhages outside. So this is a very wide field photograph in which you can see this is the macula is filled with blood, the retina is filled with blood. You have some tortuous vessels here, there, which means the involvement was much beyond the optic nerve. The disease was also involving the retina. So much of hemorrhage, finally a fundus fluorescein angiogram was done, and this patient was finally diagnosed to be a case of central retinal vein occlusion. What I wanted to say was that it is always important to know these few points to be kept in mind before we make the optic nerve as the culprit. So one thing, we always do best corrected visual acuity. So I think this is one of the most common mistakes which is done, visual acuity 612, refer to neurology OPD, and nobody has done the refraction. So best corrected visual acuity is one of the most important points. Always try to look in the fundus. All our ophthalmoscopes are given with that green light so that we can see the macula, at least see the macula. Try to see whatever area of retina can be seen so that at least we exclude the patients with retinal involvement, primary retinal involvement. Optic nerve diseases are, they have this phenomenon of relative afferent pupillary defect. And once the patient's having it, we are pretty sure that we are dealing with an optic nerve disease. Always looking for these histories of micropsias, macropsias, metamorphopsias, floaters, flashes, photopsias, which can help us know what patients might have a retinal involvement alongside. And before I finish this slide, one of the most important thing is also to look at the media in case it's hazy. And secondly, intraocular pressure. Why I say this is because of this patient. Now, this patient was referred in our OPD from periphery, and you'll be surprised, from peripheral ophthalmology clinic, whereby the patient was a 58 years old male and was sent for decreased vision from the right eye of 3 days duration. The patient also had headache, nausea, vomiting. So while we saw this patient, I think this patient, this is by the time the patient presented to us. So what you can notice over here is this mid-dilated pupil, little dilated pupil as compared to the other side. The pupils were reactive and mild congestion. So again, look at the context. The context is that this is a 58 years old male. The patient is having almost normal fundus, mild congestion of one eye, and the patient is having a mid-dilated but reactive pupil. Yes, friends, I think all of us are thinking almost on the same line. This patient had an acute angle closure glaucoma, one of the common DDs of vision loss with excessive headache. Many a times patients also come with thunderclap headache with vision loss. So do keep at least angle closure glaucoma in mind, and that's a primarily eye cause, an ophthalmology cause, but finally the patient has to be diverted towards that side. So I think these are the 3 most important questions when we deal with a patient with acute visual loss. Is the vision loss unilateral or bilateral? Is it persistent? And is it static or progressive? And the way I was talking about the context, the temporal profile, triggers, associations, and patterns of visual loss make the final diagnosis. Unilateral or bilateral? Again, I think to this august audience, we all know that unilateral would be before chiasma. Bilateral visual loss automatically takes us to beyond chiasma. So though posterior visual pathway is defined as the pathway beyond lateral geniculate body, for our practical purposes, I would say that think of optic chiasma as the level. So in case the vision loss is unilateral, we automatically start thinking of optic nerve and further. And in case it's bilateral vision loss, a field defect, we automatically go beyond the optic chiasma. I think this slide is a little busy, but I still would want to focus your attention towards this slide, which I feel is it carries very important messages. So as I mentioned, acute monoocular vision loss should always be seen whether it's getting corrected with refraction or pinhole. In case it's a persistent vision loss, the second step would be looking for relative afferent pupillary defect. And in case that is present, now we are almost sure that we are dealing with an optic nerve disease. The next question is to look at the fundus. So fundus can be having disc edema without hemorrhages, disc edema with hemorrhages, and a normal disc. So though I have written these differentials, I will quickly take you through some mild examples which will make you realize more that why this part is important for us. So again, this is a very common scenario coming to us in neurology OPDs. Young patient, 26 years old girl who came to us with periorbital pain, diminution of vision from one eye, and the vision from the right eye was 6/24 with defective color vision. So again, I would come back to the same thing. It does not take a rocket science to know that this patient is having mild disc edema, but a good vision loss. So mild disc edema with good vision loss automatically makes us to reach the core of the optic nerve. And that's exactly what we are seeing over here. The patient was having optic neuritis. The patient was having enhancement and hyperintensity in the anterior part of the optic nerve. This is how a typical optic neuritis looks like. So this is just a schematic thing I have put. So eye involvement with anterior half involvement makes it almost like a typical optic neuritis, or let me put it as an optic neuritis akin to multiple sclerosis. So before I move further, we should all know, and we can just revise that what a typical optic neuritis means. So it's acute or subacute disorder causing inflammation inside the core of optic nerve that leads on to visual impairment. But look at this temporal profile. So temporal profile says 1 week deterioration, another week, another 2 weeks, step stabilization, and then spontaneous improvement. So this is the course of a patient with typical optic neuritis, or an optic neuritis akin to multiple sclerosis. And in case this has not been met, we should automatically start thinking of other causes. This is a red flag, and then we think of the atypical optic neuritis. So another patient, a 49 years old female this time, who presented with diminution of both eyes for 2 years, right eye diminution of vision further occurred 6 months back, and for 2 weeks now she was complaining of left-sided visual loss. So though this patient had this history of progressive weakness of bilateral lower limbs, even if this history was not present, you can well understand that this was a case of atypical optic neuritis. And as you can notice, the patient was having already developed bilateral optic atrophy. You can see these pale funduses, and the patient was having left eye involvement more than the right eye involvement, visual, also seen on the visual fields. And now have a look at these optic nerve MRIs. So again, this is schematic diagram, and you can just compare this diagram to this one, showing that the entire length optic nerve is involved. The optic chiasma here is involved, and not just involved, it is thickened over here, hence leading on to bilateral visual loss. And in this particular patient, you're also having a longitudinal extensive transverse myelitis, making it a diagnosis of neuromyelitis spectrum disorders. Another patient now, again, almost a middle-aged lady, presenting with sudden onset bilateral vision loss. And if you notice over here, there is bilateral disc edema without hemorrhages, maybe a small speck of white, yellowish speck over here. And look at the optic nerves now on the MRI. Again, the whole length optic nerves involvement without involvement of the optic chiasma, leading and causing an acute vision loss with disc edema without hemorrhages. This is again another type of atypical optic neuritis, and today we call it MOG-related diseases. I'll take you to another young patient. Now this time, this is a 19 years old male with loss of vision from one eye for past 15 days and headache for past 5 days. And if you notice over here, I've just tried to make a graph showing that the patient has been having these symptoms for past, which means that these symptoms were recurrent. So we are all clear that this is some type of an atypical optic neuritis, but just have a look at this fundus. So along with disc edema over here, you can also notice some doubtful small hemorrhage in this quadrant. I do not know how well it is visible over here, but small speck of hemorrhage. So as I just talked some time back, disc edema without hemorrhage with massive vision loss takes us to optic neuritis or inflammation of the core. And in case we see a hemorrhage, there's definitely something else. It's not optic neuritis. And that is exactly what we had to see when we got the MRI done. As you can all notice, and as I've put arrows over here, apart from the optic nerve involvement, you see the involvement of the optic nerve sheath. So this is the inflammation of the optic nerve sheath, which we call as optic perineuritis, and this is not akin to demyelinating disorders like MS. This is akin to orbital inflammatory syndromes, and hence causing the atypical features which we have been seeing, which we just noted one slide back. So this is how an optic neuritis would look like, just for your comparison's sake, and this is how optic perineuritis, a tram track-like appearance, would look like. Taking you from here, as I was mentioning, context matters. So in case we have a patient with vision loss, when can it be an acute emergency? So my saying that I'm sure, would take most of you to a vascular cause. And here we have an elderly gentleman this time, 77 years old male, who presented with headache and jaw pain of 1 week duration and sudden diminution of vision from both eyes. So again, take your attention towards these fundi. So you see bilateral optic pallor, with the left-sided involvement more than the right-sided involvement, and see what you have to look at this retinal image. Do you see these yellowish white spots? So these are choroidal infarcts. These are features suggestive of choroidal ischemia. And where are we now? So just revising your knowledge on the vascular supply of the optic nerve, we have an ophthalmic artery which goes inside the core of the optic nerves and then divides into retinal arteries. into the upper quadrant and the lower quadrant, and alongside it also gives some branches which are known as short posterior ciliary arteries, which finally form a circle around the optic disc and supply the optic disc. So do remember that inside the retina, we have these retinal vessels which are supplying. Choroid is supplied indirectly by these small vessels. Short posterior ciliary artery are also the branches from ophthalmic arteries, but they are supplying the optic disc. And hence we have differential diagnosis as we'll proceed further. So now this patient, as expected, was having multiple choroidal infarcts on fundus fluorescein angiogram, along with some hypoperfusion of the disc, and we had what we wanted. We had an ESR of 90 millimeters, we had an ANCA which was positive, and sensory motor axonal neuropathy, and this patient had vasculitis in the form of intimal proliferation, break in internal elastic lamina, and extravasation of these RBCs. And these findings were very well suggestive of giant cell arteritis. This biopsy was taken from the temporal artery. So again, just revising it again, so in case we have damage to these small choroidal circulation vessels, we have an ischemic optic neuropathy, which is arteritic, which is inflammatory. And this inflammatory lesion causes or involvement of the small vesic neuropathy. In case the involvement is at the level of vein, the vein is blocked, the vein is occluded, what would we have? We will have venous stasis, endothelial proliferation, and back pressure, and lots of hemorrhages, which will lead on to this central retinal vein occlusion image, which we call as a tomato ketchup appearance, a fiery red appearance. In case the artery is involved, what will we have? We'll have no perfusion. So you'll see a pale retina, you'll see a pale fundus, and shining through the pale fundus would be this beautiful cherry dot spot because of adequate choroidal circulation, where in the area where the thickness is the minimum, the macular area, the foveal area. So you see this beautiful cherry red spot. And what would happen in case this posterior ciliary artery is occluded? In case this is occluded, you will get hypoperfusion in the area where it is supplying, and hence leading on to an altitudinal field effect. So as I showed in the diagram before, you can also notice over here, these short posterior ciliary arteries will either supply the upper quadrant or the lower quadrant because of their beautiful anatomical as in presentation, and hence we have the hypoperfusion of probably one part in case one half of this posterior ciliary artery is involved, leading on to an altitudinal field effect. And just to show you this example, we again have this elderly gentleman, not elderly, around 57 years old male, who presented with an acute visual loss from one eye, which was sudden, painless on waking up. So it is almost like a wake-up stroke. But now in this case, this patient is having an altitudinal field effect. Remember that this is a sign of non-arteritic, or let me put it this way, there's an atherosclerotic anterior ischemic optic neuropathy, and there is an inflammatory anterior ischemic optic neuropathy. The atherosclerotic one is in relation with diabetes, hypertension, and this is what it is, the non-arteritic ischemic optic neuropathy. The inflammatory one is like vasculitis, GCA, which is the arteritic ischemic optic neuropathy, which we just discussed some time back. So this gets me to this another slide of mine, which shows the various causes of binocular vision loss. So we have already covered by now that we, of course, need to rule out the causes which are corrected by refraction. We need to rule out the retinal diseases. We need to see, in case RAPD is there, then you're dealing with an optic nerve disease. And in binocular vision loss, we also have to think of causes beyond the optic nerve, beyond the optic chiasma, and inside the brain, parenchyma, and the visual pathways. So again, I've already covered about ischemic and inflammatory optic neuropathies. In case the same disease process is occurring bilaterally, it automatically makes it as one of the DDs of binocular visual loss. But the other common causes would be traumatic optic neuropathies and pituitary apoplexis affecting the eye. Along with this, I would also want to showcase over here another common cause of bilateral visual loss, which presents like a bolt. And when it occurs when brain is under pressure, let's see why. So this young male patient this time, who was an obese patient, presented with increased headache, transient visual obscurations in past, with vomitings and with diplopia and diminution of vision only over 4 days duration. And what do you see over here? Unlike the previous patients, you notice over here there's a disc edema, and there are lots of peripapillary disc hemorrhages. peripapillary hemorrhages. They are going into retina, but they are not floridly involving the retina this time. So this is a red-free image which will show you the same picture more clearly. The visual fields were totally obscured, and this is an OCT, which I will not discuss over here in detail, but it was also showing increased retinal nerve layer thickness, retinal nerve fiber layer thickness. And what did we have to see in the brain MRI? It's visible to all of you, I guess. So we have a prominent this prominent subarachnoid sheath around the optic nerve. It's more clearly visible over here. A tortuous optic nerve, an optic nerve which is almost going inside the disc. So you notice over here the optic disc indentation, and we see the left transverse sinus which was stenosed. So yes, this was a patient who was having sudden increased intracranial pressure. We could not find any secondary cause, and hence this patient was labeled as a case of fulminant idiopathic intracranial hypertension. So do notice over here, for my resident friends over here, that while we were talking about the optic nerve core, where is the damage? The damage is to the core, and hence where is the vision loss? The vision loss is in the center. But what happens when the pressure of the when the thickness or the intracranial pressure increases? So when the intracranial pressure increases, there's a pressure which is transmitted to the optic disc, to the periphery of the optic disc. And just have a note over how the retinal fibers, they enter the optic disc. So the most peripheral one would enter most peripherally. So hence, in case there's an increase in intracranial pressure, which fibers would be affected? The fibers which are in the periphery. So hence you get a peripheral constriction. This is as against the patients which we just saw, which were either ischemic or inflammatory, but causing damage where? In the core of the optic nerve. So if the damage is peripheral, you'll get a peripheral visual loss, the case which occurs in a case of increased intracranial pressure, or what we call is idiopathic intracranial hypertension. So from this visual field, I will take you to another visual field, which is of bitemporal loss. You all can notice over here, 27 years old lady who was gravida 2, para 2, presented on 7th month of her pregnancy, 27th, almost the same, 7th month of her pregnancy, with headache and diminution of vision. And once you see this, you are pretty sure that you are dealing with what? You are dealing with chiasma. Where? In the area of pituitary, and here we had pituitary apoplexy. Dr. Monika helped me manage this patient as well, I remember. This patient was referred from Punjab area. And this patient was also having mild pallor. So this is typical of pituitary apoplexy. So we have another example why I have put it over here is that whenever these patients come, we often are left with little DDs. So another thing, along with bitemporal heminopia, which can help us think of pituitary apoplexy, is the involvement of these 3rd, 4th, 6th cranial nerves in the similar area. So I have just put this representative slides of almost varied types of visual fields which can be involved in the involvement of anterior visual pathway. So quickly again taking central vision loss, optic nerve involvement, optic neuritis. This can be very avid at times when the involvement is avid. Altitudinal field effect, ischemia. Peripheral, various degrees of peripheral field effect, increased intracranial hypertension, bitemporal hemianopia, you have pituitary. And now we know that there are so many strokes which can come to us acutely with acute vision loss having involvement of the visual field. So this patient was having left hemianopia and right parietotemporal stroke. He was a 70 years old gentleman with vascular risk factors. And we all know about this thing, so I'll not be elaborating it much, but just to show you the example, the posterior we go, the more clear we become, and the more homonymous we become in hemianopias. So you see this occipital infarct, and you see such clearly defined homonymous hemianopia on one side, you have a quadrantanopia, and you have the involvement of optic radiations in the temporal lobe. Before I finish the important causes of acute vision loss, I would like to take your attention towards a few causes in which you will see normal pupillary reaction. You will see normal fundus, but you will see bilateral vision loss. And how does that happen? So this young lady again who presented with history of severe headache and blindness of only 4 days duration. And when we examined, the patient was having no perception of light, but the pupils were normal, but the fundus was normal. The patient was having the good substrate for developing of what we are thinking about. So this patient was having pedal edema, meaning to say that the patient was going towards preeclampsia, eclampsia. So this patient So the MRI of this patient was done, and what you see over here is what you would have expected, I'm sure. So this is posterior reversible encephalopathic syndrome, and you see this major vasogenic edema in the white matter tracts. White matter tracts, remember. Why I'm saying so, I'll
Dr.
discuss it
Aastha,
further.
can we conclude?
Yeah, sure, sir.
Yeah.
So do I have 2 minutes, sir, to just run through these slides?
Pardon?
So do I have 2 minutes to run through these slides?
Take 2 minutes, no problem.
Right. So just before I finish, there's nothing. So the acronym is PRESS, so posterior reversible encephalopathic syndrome, which I feel is misnomer. It's not necessarily posterior. It's not necessarily reversible. It is not necessarily encephalopathy, and it is not necessarily a syndrome. So this is a common cause of vasogenic edema leading on to visual loss. And another similar presentation with a patient who lost vision during pregnancy, and because of wake of time, I'll take you to these MRIs in which you can see, along with this vasogenic edema, cytotoxic edema leading on to diffusion restriction, involvement of the cortical area, causing wedge-shaped infarcts and causing narrowing of the posteriorly supplied vessels. And this is a case of reversible vasoconstriction syndrome. So again, the last patient probably in my series over here. So expanding the spectrum. So now what if the patient has both eye and the brain involvement? A typical example over here, a 48 years old male presented with loss of vision when he got up from sleep, but he had a history of binge drinking. So we all know methanol poisoning, it can lead on to sudden onset, extreme pallor of both the optic discs and the brain changes, like over here. I'll take you to the key points over here. So we broaden our horizon when we are thinking of what can be the cause of acute visual loss. Laterality of the lesion, temporal profile, associations make a major mark. Disc edema with or without hemorrhages, they have separate DDs. And see, look at the entire picture. The context is important. And before I go, this is the first flyer of our National Conference of Neuro Ophthalmology, which shall be held next year in our institute, PGI Chandigarh, from 10th to 12th February. I'll invite all of you over there. And this is the image of my institute, which was clicked on Independence Day. Many thanks, and Jai Hind.
Thank you so much, Dr. Aastha, for a lovely presentation. We will take the questions at the end of the session. There's a time given for discussion.
Sure.
Thank you so much.
Now I invite Dr. Monika Singla, the second speaker. She is going to speak on double trouble, that is approach to a patient with double vision. Dr. Monika. Dr. Monika did his DM from PGI Chandigarh and associate professor in DMC Ludhiana, and 54 publication in Index National and International Journals, and authored 15 chapters in various books. And she is having special area of interest in migraine, stroke, neuro-ophthalmology, and received a Best Brain B Regional Coordinator Award, received award by JCI, HDFC, and Punjab government in 2020 and 21 for managing COVID patients. Dr. Monika.
Good morning, respected chairpersons, respected seniors, my dear colleagues and dear friends. As Aastha has talked about vision loss, I shall be discussing another important topic, which is the double trouble, as the name is rightly given, the double vision. I think it's so difficult to have double vision. Yesterday I was trying to put some images of double vision, it was so uncomfortable to see. So I was thinking what patients must be feeling who are suffering from double vision. So I shall be discussing in my talk what is diplopia, what is monocular and binocular diplopia, how we take history, how we examine, how we do diplopia charting, and how we need to approach these patients. What is diplopia? When more than one image of the object of regard are seen simultaneously, it is diplopia. It is caused due to breakdown in the fusion capacity of the binocular system. Diplopia occurs when the patient sees with both eyes open, and it gets resolved by the occlusion of either eye. It can be physiological, it can be concomitant, when there is a decompensating hyperphoria, and inconcomitant when the angle varies in different directions, which can be myogenic, like due to structural lesions, thyroid ophthalmopathy, neuromuscular junction disorders, paralytic, or restrictive because of some orbital injuries. So double vision, it has to be taken very seriously. It can be a common visual concern that may be the warning sign of vision threatening the other life-threatening neurological diseases. So as we can see here, these cranial nerves, 3rd, 4th and 6th, they pass through so many vessels. So when there is a diplopia, the lesion can be anywhere in the brainstem. There can be some ischemic lesion. There can be some compressive lesions because of the vessels. Anywhere in the meninges, subarachnoid space, or in the cavernous sinus or orbital apex. So if we look for the cause of double vision, it can be varying from the nerve involvement, like 3rd, 4th or 6th nerve can be involved in isolation or in combination. There can be ischemia to the nerve itself, microvascular, or there can be infarction in the brainstem. There can be inflammatory lesion, compressive lesion, like we can see here, the aneurysm, or there can be infective tumor trauma, infiltrative lesion, cavernous sinus involvement, and there can be meningitis. In the orbit, there can be tumor or cystic lesion which is compressing the nerves, thyroid eye disease, which most commonly involves inferior rectus muscle, orbital trauma, and even iatrogenic, sometimes ophthalmic surgeries, cataract and all. There can be sometimes injury to the muscles. And neuromuscular, we know myasthenia gravis, Miller-Fisher variant, etc. So, and sometimes there can be brainstem glioma or PCOM aneurysm, which can be compressing the nerve. So now it's very important how to evaluate these patients of diplopia. First and foremost is history. History is very, very important, that what all points we need to cover to ask the history of diplopia. Then how do we examine role of a general neurological examination as well as investigations. Before I go to the histories, then first we need to understand what are the actions of the extraocular muscles, especially for the residents. Cranial nerve 3rd, as we know that it supplies 4 muscles. Superior rectus, its primary action is elevation, which is maximum on the lateral gaze, means abduction. The secondary action of the muscle is intorsion, and then tertiary is adduction. The inferior rectus causes depression, maximal on the lateral gaze, again on abduction. Secondary action of this muscle is extorsion, and tertiary is adduction. Medial rectus has only one action, adduction, and inferior oblique has excyclotorsion, and it causes elevation, which is maximum on the medial gaze, means adduction. Cranial of 4th, which is superior oblique muscle, its primary action is in cyclotorsion, but secondary action is depression, which is maximal on the medial gaze, that is adduction. And the tertiary action of this muscle is abduction. And cranial of 6, lateral rectus, it causes only abduction. So for evaluating any patient of diplopia, we need to ask these main questions. Is the diplopia more for distance or near? Is the diplopia predominantly horizontal or vertical? In which direction of gaze are the images maximally separated? To which eye does the outer image belong? Is there a predominant tilt? In which position of gaze does the tilt increases maximally? Besides, as I told earlier, that there are many causes of diplopia. So in those cases, we have to ask for the accompanying symptom. Any focal neurological deficits, any fever, any headaches, or any variability of symptoms, vision loss, etc. So what are the rules for evaluation of diplopia? First rule is we need to see the head tilt. When the weak extraocular muscle is unable to move the eye, then the head moves. Therefore, the head tilts or turns in both in the direction of the action of the weak muscle. So we can see this image. The part A, this is for the right lateral rectus palsy. We can see there is a right esotropia which is present in the primary gaze. But turning the head in the direction of the weak right lateral rectus muscle, the patient is able to maintain both eyes on the target. Second image is of right superior oblique palsy. The right eye extorts because of the unopposed action of the right inferior oblique muscle. So by turning the head to the left and forward, the right eye is passively intorted with active intorsion of the left eye and maintaining the binocular vision. Second rule is the image from the non-fixating eye is a false image and is displaced in the direction opposite the deviation. So when the patient fixates with the non-paretic eye, the false image is displaced in the direction of the paretic muscle. Third, the false image is the most peripheral image and is displaced in the direction of the weak muscle. When the lateral rectus is paralyzed, The eyes are isotropic, means crossed, but the images are uncrossed. The diplopia is worst at a distance on looking towards the side of the weak muscle. Similarly, when the medial rectus is paralyzed, the eyes are exotropic, means they are wall-eyed, but the images are crossed. And diplopia is worst at the near. Fourth rule, the images are most widely separated when an attempt is made to look in the direction of the parietic muscle. Fifth rule, secondary deviation is always greater than the primary deviation. Then committance. With the committant strabismus, the angle of ocular misalignment is relatively constant in all directions of gaze. So we can see this picture where you have shown right third nerve palsy, right fourth and right sixth nerve palsy. So this is a primary position. Here we can see the right eye turns downwards and outwards. On looking towards right, thus there is smaller angle of horizontal squint. But when the patient is seeing towards left side, the eye is unable to adduct the right eye and there is a larger angle of squint and double vision increases. In the second row, in the center, we can see the right eye turns upwards. This is a right fourth nerve palsy. On looking towards right, there is no obvious squint, but on looking towards left, the right eye elevates more as it moves medially and double vision increases. In the lower row, the right eye turns inwards in the primary gaze. When the patient sees towards right, patient is unable to abduct the right eye and there is a larger angle of squint in the direction of the action of the weak muscle, but is able to adduct the right eye, so there is no obvious squint looking towards left. So now we go to the examination. Examination, as we know, when there are bystanding other features, other accompanying features, then we know that there are many focal lesions, focal signs which can be picked up on the general neurological examination. But I'm mainly focusing on the diplopia charting for the residents. I will going to show a video. Besides this diplopia charting, the other tests which are ductions, versions, forced duction, misalignment like tropias and phorias, cover test, Maddox rod, fundoscopy, and general neurological examination. So, diplopia chart, it is a record of subjective separation of double images in the 9 positions of gaze. There are 2 methods, simple method and electronic devices. So, I have made a video for how to do diplopia charting. This diplopia charting we have done for the residents at how to make a diplopia chart on the patient's bedside when we examine. I would like to acknowledge our Mr. Deepak from our research and development department who agreed to be part of this diplopia chart. So I shall be starting from the... Good evening everyone. In today's diplopia charting, first of all, diplopia charting has to be done in semi-dark room. Second thing, the distance between the subject as well as the examiner is very important. We can see here there are 2 chairs. This chair is for the subject and the other one is for the examiner. The distance between the 2 chairs has to be about 4 feet, or we can say 1 to 1.5 meters. And the subject has to sit near the table so that he can draw the diplopia chart. So, for diplopia charting, we need this kind of paper where we have drawn 9 boxes. Another thing required is, which is the most important, is the red and green glasses, that is Armstrong goggles. Here we can see we have 2 glasses, one is red in color, other is green in color. It's easy to remember how to wear it. R for red, R for right. So, when the subject will wear, this red glass will come on the right side and the green will come on the left side. Second thing, we have this torch which has a slit-like light. So, this slit-like image we have to see to the show to the patient. It will be vertical when we are doing the horizontal diplopia charting, and we'll show it as a horizontal slit when we are doing the vertical diplopia charting. Then we have 3 markers. One is red in color, which has to be on the right side of the subject. Then green in color, which has to be on the left side of the subject, and orange in color. These 2 colored pens will be when the subject is seeing two images, red and green. If he sees one image, then it will be orange in color, then he has to draw with the orange pen. So now we'll begin with the diplopia chart. Hello Deepak. Today we will do the one image. It will be using the... Skipping this part because I was explaining him the whole procedure. Less bright. So you have to tell me that. So shall we start, Deepak? Yes. You ready?
Yes.
Okay. Deepak, please wear these Armstrong goggles. Deepak, can you see the light?
Yes, ma'am.
So, how many images can you see, Deepak?
I can see one image in orange color.
Okay. Can you draw the image in the central box?
Yes, ma'am.
With the orange pen?
Yes.
Thank you, Deepak. So now we'll move towards the left side.
Yes, ma'am.
Deepak, can you see anything?
Yes, ma'am. I can see one line in orange color.
Okay. Please, Deepak, draw this in the left box.
Yes.
Again, I will come to the center, Deepak. Then I am going towards your right side.
Yes, ma'am.
So, can you see anything?
Yes.
So, this is how we have to go in the all the 9 cardinal positions. So, once we are done with the diplopia charting, how do we interpret it? If the two images are joined together, there is no diplopia. If these images are separated, then it confirms diplopia. The maximum separation is in the quadrant in which the muscle is restricted. Fourth point, the image is displaced towards a field of action of the paralyzed muscle. Then few points to learn. Remember, if horizontal separation with uncrossed images is there, then there is esodiation, means lateral rectus palsy. If the horizontal separation with crossed images is there, then there is exodeviation, means medial rectus palsy. If the vertical separation with uncrossed images is there, then oblique muscles are involved. If the vertical separation with crossed image is there, then vertical recti are involved. We can just see these 2-3 cases for diplopia charting. 18-year-old male with no comorbidities, there is double vision which worsens on looking down with images separated vertically. Sudden onset, no diurnal variation, no headache, no speed disturbance, no trauma. Patient's conscious, cooperative, no ptosis, and pupils are equally sized and ejecting. Other cranial nerves are normal, no cerebellar signs. So we can see this diplopia chart. As I told, this red is right and green is from the left side. So we can lower quadrant, there is a maximum separation of images. As these are the horizontal lines, so this diplopia chart is for the vertical diplopia. So if there is a right lower quadrant which has maximum separation of images, then either there are two muscles which can be involved, either right inferior rectus or left superior oblique. So as I told, we need to see whether it is a crossed or uncrossed diplopia. So as the green line is outside, so this has come from the left side, so there is a maximum separation with crossed vertical diplopia. So likely muscle is involved is left superior oblique, right, because the green line was outside. So we can see this diplopia chart. As this is vertical lines, so this is for the horizontal diplopia. We can see the maximum separation of images is on the right side. Again, on the right side, there should be the red line which should be outside, but green is outside. So it means it is a crossed diplopia. If there is a right side wide separation of the images, either there has to be right lateral rectus palsy or left medial rectus. As there is a crossed diplopia, so it has to be the medial rectus. So here we can see this diplopia charting is for the, again, vertical diplopia, horizontal lines. On the right inferior quadrant, there is a maximum separation of the images. The green image is outside. It is coming from the left side and we are seeing the maximum separation on the left side. On the right inferior quadrant, if there is separation of images, it has to be either because of the right inferior rectus or left superior oblique. As it is uncrossed, so it is likely to be left inferior rectus palsy. This is how we can interpret diplopia charts. Other things we can do, cover test to look for the phorias and tropias. Tropias, as I told, that on primary case, when we can see there is a squint is present already, then it is tropia. But when it comes on the cover test, on primary gaze, you don't see any patients complaining of double vision, but otherwise there is not significant misalignment of the eyes. But when on the cover test it happens, then it is phoria. And another test to see for the rectus palsy is Maddox rod test. This is on the right gaze. When we put Maddox rod, when the patient sees, there is a wider separation of the images. On looking straight, there is a less separation, and on the left gaze, this separation disappears. So suggest only right lateral rectus palsy. For the trochlear palsy, Park-Pilshosvik test can be done, and double Maddox to assess which eye is hypertropic in the primary gaze. So we can see here the left eye is hypertropic. In case of left hypertropia, the following four muscles, either depressors of left eye, that is superior oblique or inferior rectus, or elevators of the right eye, that is oblique, are supposed to be involved. In the fourth nerve pulse is higher. Then step 2, we need to see which lateral direction has the worst hypertropia, and in which head tilt direction is a hypertropia worse. Then another method is double Maddox rod method. So finally, how we need to approach, to conclude my slides, diplopia, when we know it is monocular, then we should refer it to our ophthalmology colleagues. But if it is binocular diplopia, we need to see if there are other neurological signs and symptoms. Probably we can follow the stroke protocol MRIs. If there is isolated diplopia of 3rd, 4th or 6th, then if the patient is more than 60, we should do ESR, CRP to rule out arthritis. If there is a third nerve palsy in isolation with or without pupil sparing, we should do urgent scan and CT angio. If there is 6th nerve palsy, again we should rule out raised ICP, and neurologist should see in detail. If there is a combination of cranial nerve palsy, then urgent MRI should be done to look for any cavernous sinus or orbital apex syndrome. So according to accompanying symptoms, we can keep our possibilities. If the patient says it's my worst headache of life, then probably we are dealing with subdural hemorrhage. If headache with cranial nerve palsies, pituitary apoplexy or ophthalmoplegic migraine, large unreactive pupil, compressing pathology because of picomannerism, if weak cranial nerve 5 involved with loss of facial sensations, then cavernous sinus lesion, diplopia with areflexia and ataxia, Miller-Fisher variant, diplopia dysarthria, dysphagia, tics paralysis can be considered, headache, jaw claudication, giant cell arteritis, and these can be the stroke syndromes in the midbrain. If there is a fatiguability, then myasthenia. If inferior rectus is involved with ptosis and chemosis, then probably thyroid eye disease. So finally concluding, systematic approach in history and examination can help diagnosing challenging cases of diplopia. In case of diplopia with certain clinical findings, because when there are gross findings, we know that is 3rd, 4th or 6th nerve involvement. But in case of subtle, diplopia charting can be very, very useful in diagnosing cranial nerve involvements. Thank you very much.
Thank you, Dr.
I would
Monika,
like to
for
thank
such
the organizing committee, Dr. Arundar, for giving us this opportunity. I would like to acknowledge Dr. Gagandeep sir, who motivated me to make this diplopia chart, how to do diplopia chart. Thank you so much.
Thank you, Dr. Monika, for such a nice presentation. It was really a very big topic, and you covered it very nicely, and they described the test very nicely. And we will have a discussion later on after the third final talk. And I just hand over to, I think.
If there are no further questions, we'll conclude this session and hand over to the organizers. Thank you so much.
Thank you.
I thank our panel for the amazing and informative discussion on the complicated topic of neuro-ophthalmology and making it simpler for our students. And for the information of the entire audience, the chairpersons and speakers, there are 3 to 4 25-minute talks on each session, and there will be a 5-minute discussion at the end of this talk.